What's up, FRT community? You, mm, this is episode 4 of RTalk. And today I have my very first RN on this channel. His name is Vincent Hernandez. And I promise you, you want to watch this one. Let's dive in. What's up, future respiratory therapists? Today, RTalk, episode 3, as I mentioned in the intro to this episode, and I'm today joined by Vincent Hernandez. Vincent, thank you so much for being here with us today.
Hey, Joe, Respiratory Coach Extraordinaire. Thanks for having me. Vincent Hernandez.
Hey,
Good to
I'm so glad you're here today because I think we're going to have a great session that so many RTs as well as RNs might just learn something from. If you don't know, Vincent is an RN. So this is the very first nurse that I've had on this episode or on this channel in this live type setting. And we're excited to talk about a lot of things that go on between nursing and respiratory and just what do we do to bridge the gap. But before we get into that, Vincent, tell us a little bit about yourself.
Thanks, Joe. So Vincent Hernandez, I've been an RN for 5 years. I grew up in intensive care units. So that was my first job out of nursing school, went right into a neuro ICU. But we weren't just neuro guys. It was sepsis, SIRS. We saw tons of that. We had a cardiovascular unit in this particular hospital. That was fantastic. So you name it, I did it other than trauma as an ICU nurse at this particular facility. Done med surge. I've done surgical ICU. I was also a paramedic for 10 years. So did a lot of fun stuff, darting chest, intubating in the field. Worked in a really heavy call district. So just saw a lot of good stuff, Joe, but I appreciate you having me on.
Yeah. So one of the things I love when I talk to, I heard a paramedic or an EMT say this one time, and I never forgot it. Because as respiratory therapists, a lot of times it depends on where you work, obviously, but a lot of times we don't get the opportunity to intubate in the facility. They call anesthesia in, anesthesia drops their medications, the patient goes to sleep, they intubate to make it look real easy. And I had an RT one time tell me, it was like, but anybody can intubate a patient that's asleep and sedated, and that's true. And they were like, why won't they let us intubate them on the spot? Yeah. And that might be true too. But what it always came back to was this one paramedic would say, try doing it in a truck upside down. And I love that. I love the fact that you have that experience. And I can't imagine the difficulty of intubating somebody in a moving vehicle. You got any stories to share about that?
Yeah, Joe. So that's funny that you say that because our saying is try to intubate upside down in a car with blood all over your face in a snowstorm, right? And and you got paramedicine right there. So I guess probably the best story that I had, and listen, I'm not here for the glory. I don't sit around. Well, very select friends I actually sit around with a drink and talk about our glory stories. But one in particular, I had a gentleman that was in his RV, and he was moving cross country with his wife. It was just him and his wife. They were elderly, and he had a massive stroke while in the front seat, while driving, slammed on the gas, went into a ravine. And it was so much so that the RV was ready to go right into the ravine, but it was hanging on by a thread, right? So we're called, and I'm EMS, they dispatch fire. Anyway, they make entry, they extricate the gentleman out, and he was completely unconscious. The guy was in bad shape. So I was tasked for the female that was in the passenger seat, and they had maximum intrusion of the front of the vehicle into the compartment, crushing her pelvis. So you can imagine her legs were just like spaghetti, so to speak.
Oh,
so she was alert and oriented. She was freaking out, screaming. I mean, she sees her husband being pulled out of the RV. She's freaking out because she doesn't, one minute she's looking out the road, next minute she's in a ravine. So we gave her my favorite drug, ketamine. And, so she starts to kind of ride the K train, and that was made it so that we can pull back on the dash and we can extricate her out. Well, we end up starting bilateral IVs in the unit. So, or excuse me, in the RV. So that was fun. We're doing everything in there. Well, then we start feeling the RV start to go down the embankment towards the right, towards the ravine. And we're like, oh my God.
Oh my gosh.
And of course, I'm about 185 pounds, 6'2". So I'm a wiry string bean. They sit me in there because everybody else is over 200 pounds. And they're like, Vincent, you go ahead in there. And I'm stuck in here. I'm the only one, man. So here I am trying to pull this woman out on a backboard. I'm getting out there. And then, so she goes unresponsive, unconscious, apneic on scene. So we had to intubate her, you know, talking about what you were just talking about, you know, laying down, prone in the grass, intubating, you feel all cool and stuff like that. And then, you know, we airlifted her and yada, yada, yada. But the cool thing with that is that we always followed up with our patients. We airlifted that guy. And I followed up the next day and they found that he had, like I said, a massive stroke, but no life-threatening injuries to where they were able to rehabilitate him. A month later, he walked out.
Wow.
It's crazy. Him and his wife. Well, his wife was in a wheelchair, but yeah, it's pretty amazing. Pretty amazing.
Wow. Wow. That's impressive. And that's such a great story. Such a great story. So we're going to get into a little bit deeper topics here. As you know, the way this rolls, you talk, I'll write some key points down that you're going to say, and we're just going to see where this goes. Okay. So what I kind of like to want to first do is say, you know, you're the first RN I've had on this episode, and hopefully not the last. So if you're an RN watching this and you want to collaborate, send me a message. I'd love to hear from you because I'd love to collaborate with as many different people. Maybe you're not an RN. Maybe you're an OT or a physical therapist or a radiology technologist, whoever you are. I would love to collaborate with you also. But I want to know from Vincent, man, why did you reach out to me? What is it that was inside of you that made you want to send me a message?
Yeah, no, that's a really good question. I really appreciate it. So I want to start by saying that I really feel like I'm in a really special position because yes, I'm an RN, but I've also been able to bridge the gaps and see what you do and see what other people that are part of the care team do by having my paramedics experience. That really tied in, having that pre-hospital, yes, but really kind of appreciating the respiratory care, right? Physician assistants, other nurses, you know, other disciplines. So I feel like I'm in a really just cool satellite position to see everything. And the reason why, and that feeds into the answer to your question, the reason why I reached out to you is because my wife is a respiratory therapy student, woo-woo. And so she's, so respiratory coach, she lives by you, man. Like, you know, if she's having a difficult time in school, she goes to your YouTube page. She goes to just all the awesome stuff that you put out, all the episodes that just really break things down into a really palatable way to understand, minus all that filler, right? Minus all that other jargon that they have to throw in because of education. And listen, I'm not hating on education. I understand why it's there, but you cut to the chase. And I really think that's super important in the Zoom world. That's the one reason. The second reason is I was like, man, this guy is really, his teaching style is special. I like to consider myself a pretty good teacher. I own Inspire CPR and Inspire Medical Academy. We have a medical academy. I tutor RNs in 3-4 different schools in San Antonio. So I'd like to think that I'm kind of a baby version of you, right? That I can cut to the chase. I give the students what they need, kind of in emulating or reiterating a conversation that you and I had. I'm able to bring the clinical aspect to the book world, and we're able to marry those two in a way that nobody's doing out there.
Yeah.
So I thought what you're doing is really special. And I was like, I got to collaborate with this guy.
How important do you think that is? How important is it? Because we understand, you're an educator, I'm an educator. Right. How important is it to understand that as educators, we have to prepare these students to pass a test.
Right.
But where does the clinical application come into that formula? How do you weight those two? Do you put more weight on one or the other?
Right. No, that's a really good question, Joe. So this is real talk, right?
Yeah.
Okay.
Be how you want to. Be colorful if you want to.
So the problem with education is it's all based toward, or it's all predicated on passing a licensure exam. You know why? It's not for the betterment of the student, for the industry. It's because of their pass rates that they have to report to the certifying body. They have to have certain numbers. If the numbers start dropping to a certain level, there's probationary status that there's consequences.
Yep.
So unfortunately, I'm sure that all of these educational institutions started out in the most altruistic, from the most altruistic point of view. However, they just got lost because of these tests. Okay, these standardized tests, which we know as compared to most of the other world, places like Japan and whatnot that have different education models, it doesn't necessarily work all the time. Now, I'm not here to debate education. What I'm going to answer your question. I really feel like, yes, the fact is we have to get these RN students to pass their boards, right? They have to pass the NCLEX, man, because unfortunately, if you don't pass the NCLEX, you're not going to work and I'm useless. However, it is more important to me to produce people who are not going to kill patients, right? Who know how to work well as a team, who can communicate with doctors. I read the stats for like the RNs. I want to say within 3 years of you graduating, most of them, a good majority will actually leave to go into other fields just because there's no support. It's a dog eat dog world. It's nurses eat their young, eat their own. Have you heard that?
Yeah.
And so my idea is, yeah, exactly why. There's no reason, because we should all be working together for the patient, but we lose that. So my idea is if we can change it from the inside, change that culture, change that mindset, well, we might produce better human beings and better outcomes for patients, right? I mean, that's what it's all about.
Oh man, you're getting me in my feels, Vincent. You said better human beings.
Right.
I got to put this down here. Because that is, I'm going to actually draw a circle around this one, because that may be your ultimate statement today. I don't know. We're going to see what else you come up with. But you got me in my feels when you said that. I agree with you 100%. The world that I work in respiratory therapy, I'm with an institution. And of course, we're graded on pass rates. And so we have to teach to an exam. Well, here's the deal. We're not just graded on pass rates. We're also assessed on attrition. Now, let that sink in for a second. If we have too many people fail our program, then we are deemed.
Yeah.
And then on the backside, so what do? We put in programs and things to keep people from failing. And then these people turn into not being able to pass the exam. And we get dinged for not being able to pass the exam.
Right.
And so it's like this really complicated bureaucratic red tape that, in what you said, the human aspect of it is completely lost, because the goal of whether you're nursing or RT, respiratory therapy, or any other health science field, the ultimate goal is humanity, is taking care of and understanding that as a student, you are going out, you're going through a program, and at the end of it, you're going to pass an exam, get a license, and you are going to be privileged with taking care of my mom.
Right.
Let that sink in for a second. Everybody watching here, just let that sink in. Like, you get to take care of my parents, my child, maybe me, maybe Vincent, his parents, his children, his wife. Like, what an honor. And yet the educational process gets caught up in bureaucratic red tape. And it is such a frustration for me. And I know it's one for you also. So I appreciate you bringing that up, because that's a big deal. I can tell you're passionate about that.
Yeah, absolutely.
Let's talk about here for just a second, Vincent. Let's talk about the relationship between registered nurse and respiratory therapist.
Mm.
If you had to describe it throughout your experience, would it be, how would you describe it? I'll leave it at that.
No, that's a hot topic right there. The uncomfortable thing about being in nursing school whenever I was going to nursing school 5 years ago, is that the message was, and again, all honesty here, RNs may hate me that are watching this, but it's true, because you heard it. It was that we are the original. We are the original occupational therapist. We are the original physical therapist. We are the original respiratory therapist. Okay, we can do everything. That was more or less kind of the message. Now, having that 10 years of experience being in EMS, I was like, I know, I've seen it, right? I've worked with some nurses that I thought maybe shouldn't be nurses anymore. And I've worked with some awesome, badass nurses. Okay, I'm not hating on RNs because I'm an RN, you know, I obviously appreciate it and respected the field. Otherwise I wouldn't have gone into school. However, that was the embedded, ingrained mindset. Okay, so then I get out, not really truly understanding what a respiratory therapist does. I know that they existed, but I've never worked in a hospital, okay, or, you know, just only as a PCA. So what does a respiratory therapist really do? Well, I see them at bedside. I see them giving treatments. I see them in there with the doctor whenever they're intubating. But what really do they do, right? I see them hooking these really cool devices up to the tube, to the balloon, you know, but nobody really explained what they do. And then working in the ICU, we get a memo from our medical director that says, if you touch the ventilator, if I witness an RN, a registered nurse, touching the ventilator anymore on intubated patients, that you will not only be fired by, which I guess he took it upon himself to be able to fire people at this point, but I will come after your nursing license. So at that point, I put 2 and 2 together and realized, wow, not only do we not know what you guys do at all because we weren't taught that, but nurses were also adjusting ventilator settings on patients in the ICU on their own. We're taught to a certain extent, right? You know, tidal volumes and things of that nature, but guys, nothing like you, because that is your specialty, right? That's your baby, is everything cardiopulmonary. So at that time I said, there's a problem here, because I heard all the nurses in the break room, well, we should be able to adjust the vents, you know, screw this, screw that. You know, they're never around and whatever else. And I'm like, but you're not understanding. First of all, there's a respect there. You're not respecting the job, the position, the expertise, right, of this other discipline. But you're also not aware of what you're doing to the patient right here and the disservice, right? Oh, we see low 2 sats, so let's bump up the FiO2. Well, what? So that in a nutshell is an explanation just of how toxic, honestly toxic, the partnerships are between any discipline in the hospital. And the whole idea of nursing, the whole mindset is that it's supposed to be holistic. You bring everybody in like a circle with the patient in the middle, right? Everybody participates for the care of that patient right in the middle. It sounds good in theory. It's not practiced too often, especially with the mindset that a lot of these older practitioners have. It's unfortunate.
Yeah, I agree with you. Now you did a little bit, you kind of called out your own field.
Yeah.
And you know what? It takes guts to do so. So if you'll give me just a few minutes, I'll do the same for my field. There's too many respiratory therapists out there that are annoyed with nurses calling them about a breathing treatment, or calling them about a need that they have. And maybe you're at lunch, or maybe you're at breakfast, which I don't even know why we get breakfasts in healthcare. Who gets paid to eat breakfast? Like who goes to work and then goes, I need to go get my breakfast? Like when did that become a thing?
It's usually huddle and then breakfast.
Yeah, like what is that? Like that doesn't even make sense. But nonetheless, I have heard respiratory therapists be extremely rude to nurses for calls. And I think about it like this. Like if I had a plumbing problem and I called a plumber and that plumber treated me like I've seen RTs treat RNs, I would hang up.
Right.
Why would I call you if I need you? And I think that's where this all comes back to me, is that for my profession, for respiratory therapists, you have to understand that if a nurse calls you, it's because they need you and they're asking for your services. And we are a service industry, and we should respond without hateful comments, without attitude, without, I'm at lunch, I'll be there when I'm done. What if somebody dies while you're eating your Subway sandwich?
Right.
This is not okay. This is not okay. And it all brings us back to this point that I would love to get to a point. And this is one of the reasons, Vincent, why I was so thrilled to have you on for this episode so early on. This is only episode 4. I plan on having 400 episodes, and you're number 4. And so congratulations to you. But I really think it's important, because what I'm looking for is for people like you and for RNs like you who want to bridge the gap, and they want to come together with RT. And I'm looking for RTs that are wanting to bridge the gap and work with nurses. We should not be enemies or foes. We should be holding hands plutonically at the bedside for the betterment of the patient. Honestly, let me say it like this. When it comes to registered nurses and respiratory therapists at the bedside in the hospital settings, we should be best friends.
Yep.
And I really believe that. Yep. And it doesn't mean you have to get along with everybody, but we all have to move towards the same objective, which is humanity and patient care. So I love that idea. I love the way, you know, the passion you bring to this conversation. You're not hesitating to call out on the negative views that RNs have. You know, I've heard an RN before say, well, why can't I just turn the knob?
Yeah.
Well, some knobs can harmlessly be turned, but not all knobs. And so I think that's an important place to go. So let's talk about how do we bridge the gap. So let's stop with all the negative. Now, as I think both of us are positive individuals, let's focus on the positive. How do we bridge this gap? What are your thoughts?
Well, no, those are really good points. And I'm glad that we could be honest and have real talk about what it is out there, because if we can't be honest, we can't fix the problem, right?
Absolutely.
So, and all of your points are spot on. So whenever I think about the solution, right? Well, I first go to it comes back to education. Remember I said that in the education process in nursing school, we weren't really told what you guys do. We know that the respiratory therapist is there, and okay, respiratory, that tells me that they have something to do with RT, with the pulmonary system. However, I really don't know what you do on a day-by-day basis, but whenever I get out into the field, right, whenever I'm on the floor, you're right, man. It's just you and me that are in that patient's room most of the time. Right? You have a tech that comes in, takes vitals. I love my techs. I have a PA academy. I love them. But it is you and me, man, that are at that patient's bedside. The doctor does their little magic, right? They do their thing and they move on to the next patient. And you and I are left to manage this patient, right? We're in there for hours if we're intubating, if we're doing whatever, man. So it is, you're right, man. We have to work together. And for that, we have to understand what each other do. I think that it's noteworthy for respiratory therapists, if I can send a message to your bright-eyed, you know, eager, bushy-tailed RTs that are out there, I want them to know that not RNs are made the same. I had, again, extensive background in medicine before I became an RT. Emergency background, man. I was always thinking about just high level, you know, what am I going to do? What am I going to do for the future of the patient? Yes, I could take an airway, but you know what? They're probably not going to come off that tube. So let's go ahead and think about BiPAP, you know, CPAP, whatever. You know, I already had that in thought process, but you have these RNs who this is their first time in a professional education type program. They are 19, 20 years old. You imagine when making these type of decisions at 19 or 20 that involve patients' lives? That's crazy.
That's crazy.
And on top of that, in nursing school, we're like a generic foundational, just non-specified. We're like a stem cell, man. You know, we are not differentiated. We're just baseline. We're taught, and I had a student yesterday that told me this, and I love it. We know a lot about very little, right? I mean, we know a lot, but it's spread out over a period. Then you get out, and then you go into an ICU. Then you learn hemodynamics, right? You really understand them versus being able to regurgitate them on a test. You really understand, you know, pathways for like higher level stuff, HELP syndrome, you know, just whatever, all those obscure things. Or on the other end of the spectrum, again, I'm not hating on anybody.
Sure.
Okay? You go to ICU, ER, or you can go to med-surg where you have 8, 9 patients. Generally, these patients are stable-ish, okay? They're walkie-talkie, and you're providing basic just nursing care. So that's the one thing that I want to drill home and drive home. is that nursing students that come out are just blank slates. Literally, they know a lot about little.
Yeah.
So I think that if other disciplines can really understand that, then they can understand the difference between talking to a med-surg nurse versus an ICU nurse. That mind's just going to be at a different place, man. Your tele nurse is going to have different priorities than your, than your higher specialty nurse. I think that's probably the first place to start.
Yeah, and I think it's clear. First of all, yeah, I know you asked me before we joined this. You sent me a text. You said, "Is there anything off limits?" And I said no, but I forgot to tell you that we don't use the word "just" on this show.
Oh, I'm so sorry.
That's okay. That's okay because I didn't tell you. So to all the nursing people, nobody is just a med-surg nurse. If you're out there, then it's exactly what Vincent said. You just have different priorities,
right.
And your value is still equivalent to that, because at the end of the day, all we're trying to do is how do I say this? Man, I got this thought in my head, but I can't formulate it. We're trying to return humans to a normal state of life, or to at least a different state of normal. And everybody plays a role in it, and everybody is so valuable. And I think what you're talking about right now is perspective. What perspective does a high level, cardiac ICU nurse come from versus a high level med surg nurse come from? They have two different priorities, right, and they're not the same. And I think that's important for respiratory therapists to understand, because as a respiratory therapist, a lot of we're not always in one area or the other. Now, some of you may specialize in trauma ICU, cardiac ICU, that's fine. But you're gonna find your day sometime on the cardiopulmonary med-surg floor. And you have to be able to adjust your perspective to understand the priorities of the staff on that floor. And that's a fair statement, man. That's a deep statement, actually. And that's no harm or no foul or no ill will to anybody. That's just saying we all exist with different purposes, and we fulfill those purposes, and we fulfill them a lot of times at different times. And that's a great perspective. So one of the things that I think about, and I've been thinking this for years, and I've said it a few times on this channel, is what would you think as a nurse? Okay, so you're an RN and you're sitting in your I'm assuming y'all have monthly, what do they call them? UBC meetings, unit-based counsel. Right. You're in your unit-based counsel. What would you do if I showed up in your unit-based counsel one day? Just said, hey, I'm just here to watch and listen and learn. What would that impact have on the nursing staff?
Well, I can tell you that has happened before.
Good.
It almost feels like you're in trouble, right? Like, oh, somebody on the outside that's not, because medicine, I'm not going to even say nursing, medicine is very cliquish, okay? Yeah. And you feel almost like under attack, right? Like, who's this outside person? Am I being audited? Are we in trouble? What's going on? So that shouldn't be the way it is, right? It should be multidiscipline.
Yeah. Yeah. I think that's where I've been trying to encourage RTs to go to nursing UBC councils. And likewise, I don't know why I haven't before, probably because this is a respiratory therapy based channel. But I think nurses should come to the RTs meetings, because that's the only way we really truly start to understand each other, and we really start to realize where we can help each other.
Agreed.
And so I love this idea of getting involved in meetings, not for, like you said, nobody's in trouble. I'm just here to listen. And I just want to give some insight onto where we come from as RTs. And once we start to understand each other better, oh man, the roof is limitless.
Agreed. I had a situation at one hospital I worked at where they were implementing a grand round type situation onto the floors. And it was obviously the physician. You had everybody who's involved in that patient's care, down to case management, the diabetic instructor, but you had a respiratory therapist that's right there, right by the doc as we're walking through. And that's awesome, because now we're all listening, right? We're now all listening and communicating as far as what the what we're going to be doing for the patient, what the plan is, but we're also being able to pick the brain. What I thought the magic was, is that I can pick the brain of the RT and see where they're going. Because there you start understanding the mindset, right, of you guys, because your priorities, your brains go to different places than us. Here I am, 60,000 different other things, and you guys are really touching on stuff, and I'm like, oh yeah, man, that's good,
Yeah, yeah, I like that a lot. Hey, what would a nurse say? What would a nurse say if an RT department came, maybe not one nurse, but a nursing department, if a respiratory therapist department was to come in and say, hey, I know you guys are busy. We want to take over and help manage and monitor chest drainage systems. What would RN's response be?
Ooh. Well, okay. I've worked at some really good facilities that were going towards magnet status, and their whole mindset is education is priority, right? And having more hands on deck is for the betterment of the patient. So I would like to say that those facilities would be like, okay, cool. Let's talk about how we can collaborate. Maybe a director comes in, starts working out, a system, a protocol, maybe to where there's checks and balances. I think that would go over semi-well. Now, I've worked at some other facilities where stay in your lane. Right? Stay in your lane. I'm going to stay in mine. I'm going to do what I do. You're going to do what you do. And then we're good. And unfortunately, there's no evidence base there, right? There's no evidence basis.
Yeah.
It's just all about, we've been doing this for the longest time. This is how we've been doing it. And we don't really feel comfortable deviating from that.
Yeah.
So I guess to answer your question, because it's kind of vague, my answer, there really is no consistency.
Okay. All right, that's fair. I like it because here's where my mind goes. Now you have to understand that my mind is on the progression. Like I look to the future, and I'm thinking to myself, you tell me to stay in my lane, I'm thinking chest tube for pneumothorax, that's my lane. Chest tube for pleural effusion, that's my lane. Chest tube for empyema, that's my lane. And so I'm thinking this is my lane, and what I'm really trying to do is to reduce your overall workload. Because I see nurses and I have a ton of respect. I mean, I love all of my nurses. You go to the facilities that I work at, man, they know I love them. I speak to every single one of them, and we have a great working relationship because I know how much work they're doing. And I'm looking at it going, it seems like something that's in my lane that I could alleviate from you so that you could spend time more in the realm of some other area. And I don't know what that area is because I'm not a nurse. So I don't know what you're not doing. I don't know what I don't know. That's what I'm trying to say.
Exactly. And I think that you just hit something huge right there. And I love that. And I think ultimately it comes down to what I started with by education. If you guys understood and you guys had just a general idea of what we do in your respiratory therapy programs, and vice versa, if we had that, then we would see, like you're saying, stuff that maybe we would consider out of your lane is not, that's your specialty. You are the qualified practitioner for that. And we should let you do your thing, right? Instead of interfering and feeling like we have to micromanage and control everything. Let's just say this is for the betterment of the patient. We're all heading to the same direction.
Exactly. That's exactly right. Hey, why do you like teaching so much?
Oh, that's a good question. So the answer is I never consider myself a teacher. I loathe the idea growing up of becoming a teacher because it just seems so boring. Like there's no way I could stand in front of people. I'm nervous. I'm really shy. Can you tell? I'm really shy of people. I get sweaty under the armpits and my hands start perspiring. And then, I started teaching some CPR, ACLS, PALS for my nursing students coming out. And I saw exactly the need that you see with your respiratory therapy students. There is a gray area that's not being touched on that is missing in education, right? Like you can like schools get from A to C, but where's the B, man? Nobody's talking about that. Nobody's bringing in any of this stuff that we just talked about, like real talk, how to change the industry and make it better, right? So I said, okay, cool. Let me just grab the bull by the horn, so to speak. And I feel like whenever you're passionate about something, it just comes out. You just vomit it out. And it's just been easy for me. So I've been very blessed with the audience that I've had with my awesome students. They're just phenomenal. They listen to me for some reason.
Yeah. What's your teaching style? I'm trying to get you to cuss.
I cut the shit, right?
There you go.
I cut the shit, man. You know, I listen. I respectfully interject my opinion that it doesn't matter the personal biasness that your instructors who, you know, I told you this the other day, who met Florence Nightingale back in the day and just won't quit nursing, and now they're bringing it to the industry and poisoning the well, so to speak. And it does, none of that stuff matters. Why are we here in the first place? We're here for the betterment of the human race, right? I mean, that's why we're all here. It's not because, you know, I love to be on my feet for 14 hours a day and come home smelling like garbage. No, it is for the betterment of people. So let's not forget that, you know?
Yeah,
So
I love that.
That's my teaching style. Yeah.
I love it, man. I love it. I was just trying to bait you there, man. I played right into it. I feel like I just got it down fast.
I've been trying, my potty mouth, man, I've been trying to keep it on lockdown.
All right. So, Vincent, you got anything for me? You want me to answer? You got any questions or pressing questions for me that you want me to answer? If not, no big deal. I just thought I'd throw it out there.
Yeah, Joe, I have, and this is probably just a very worldwide type of question. But you know, you're in the world that we're in right now, in the Zoom world, because of this COVID-19, a lot of programs, educational programs, have had to pivot, call audibles, and not picking on anyone in particular. Sure. This is my worldwide based knowledge or experience from what I've seen in the schools that I work with. They're struggling. They're struggling to convert the mechanics into this new framework, right? So you have these students who are terrified, right? Graduating these programs, respiratory therapy, RN, it doesn't matter. They're all feeling the same way, okay? So what is your best advice to give a student that's got a COVID class, right, so to speak, in the fear that they're going to come out and be inadequate, that they're going to be unprepared, and that they're going to eventually hurt somebody? What's your best advice?
Yeah, that's a phenomenal question. I thought you were going to go another direction with this, but you're asking about the class that's about to graduate, how to deal with those fears. It's funny because literally just what's today? Today's Thursday. Yesterday, mm-hmm. I actually told a group of students that you were graduating behind. You were not at the level at which I expect my students to graduate with 6 weeks prior to graduation. Like, let's just be real. This is being recorded in April 1st of 2021. So I just want to give that for reference for anybody watching. April 1st, 2021. There's a group of nursing and respiratory therapist students who are set to graduate in May of 2021, and they feel behind, and they should, because honestly, most of you are behind. Now, the best piece of advice I can give you is to go out into your work experience. You're going to get jobs. Like, let's just face it, Vincent, they're going to get hired. Nobody's going to go, oh, never mind, we'll wait for the class of 2022. No, they're going to hire you guys. But it is your responsibility to not allow yourself to be put into a dangerous situation. You have to know your limitations, and you have to know your comfort level. You have to know it's different from what these employers have been working with in the past. And some employers, hopefully, if employers, I'm begging you right now, understand that the orientation process needs to be extended. It must be extended for these students. Now, if you go to work for a place where it's not extended and they go, well, nobody's ever had a hard time in the past, then go find a new place. But at the end of the day, know how to contact your team lead. Know how at any second of your shift to reach out to a person of influence that can help you. Because the last thing I did, I mean, this gets me, I got chills right now saying this. The last thing I want for any of these graduates of 2021, whether it's nursing or RT or any other health science program, is to go out and hurt somebody. So recognize when you're in a situation, when you're not comfortable, and seek out help. I promise you will never get in trouble for asking for help. And your employers are just going to have to understand that that's probably going to happen more this year in the coming months than probably really ever before. That's my number one piece of advice, Vincent.
I like that. So just to add, kind of piggyback on what you're saying, it's more important than ever to have this conversation about interdisciplinary working together, because these students that are coming out, we're really going to have to rely on the professionals that are around us asking for help. It doesn't matter if you're an RN, ask an RT.
Yes.
What do I do? In your experience, I'm scared, help me. Okay, I feel like there's something wrong. Okay,
Yeah.
Or respiratory therapy students, ask your RN. We all are working together. Okay, yeah. And so I agree, and that's exactly what I tell my students is reach out, ask for help. If you're the smartest one in the room, you're probably the dumbest, right?
Hey, that's true. If you're a graduate in 2021, for sure. Now, here's the other thing you just said is you said, if you're an RT, you don't know what, talk to your nurse. If you're a nurse, you don't know what, talk to your RT. But think about this situation, Vincent. Think about here coming up in June, July, August of 2021, where there are going to be class of 2021 nurses working with class of 2021 respiratory therapists.
Right.
Both of you be big enough to understand that we need more experience in this room. And there is nothing wrong with that. Like, nobody's expecting you to know it all.
Right.
It's just not the way it works. This is the time when I've touched on this multiple times. It seems like it comes up regularly over my last several videos. But this concept of faking it till you make it is terrible. Because you don't ask for help when you want it. And when you graduate, that is the prime time to say, hey, I just graduated, I don't know, and I need help. And you're not going to have to fake it, because that's honesty. And I promise you, you'll get more respect and become a better respiratory therapist as well as a better RN down the road if you will seek out help in the early days of your career. And I don't mean early days, I mean early years. Because it's going to take years to really get to where you feel like you got it. How long did it take you, Vincent, before you walked into any room? No, I'm talking not knowing anything about it. They just said, hey, Vincent, we need you in room 201. How long did it take you to get to that point to where you were not nervous walking into any unknown room? Do you remember?
You know, Joe, it was really at my 3-year mark is when I said I could go anywhere in this hospital and probably pick that patient up and I'd feel okay.
Yeah. For me, it was about 4 years. As an RT, it was about my 4-year mark when I went. They were like, where are you going? I was like, room 307. They were like, what's going on? I was like, I don't know. They were like, you don't have any idea? I was like, nope. And they were like, you nervous? I was like, nope. Like, it was about 4 years for me. So what that point is looking at two experiences. How long have you been a nurse, Vincent?
5 years.
5 years. So you're looking at two, experienced individuals, who are at the point to where they've been through everything you've been through. And that's kind of one of the things that, a lot of times younger generations or new grads get insulted. Like, well, I know it. I know stuff. I know you know stuff, but I also know how you feel right now.
Right.
And so just trust us that during those nervous days, seek out help anytime you need it, because it's not worth injuring a life. It's not.
That's a great point, Joe. And I feel like if we can flip this thing on its ass a little bit and make anything positive out of it, COVID has really been the great equalizer to all of us. It humbled us. And I promise you that mindset of fake it till you make it, you're absolutely right. Gone are the days of that BS. Nope, no more.
Yeah, no more. No more. All right, let's recap here, Vincent, real quick. You finished this. I baited you into cussing. You said, cut this shit. Like, let's just make this education world simple. Like, it doesn't have to be complicated. If you're an educator watching this video, then I'm going to challenge you to cut the shit and get to the points that matter and simplify these concepts for these students so that they're not overwhelmed with the minutia. That's really what it comes down to. Vincent said, let's pick the brain. I love this. I wrote it down here for a reason. You were talking about multidisciplinary rounds. and really have an opportunity to pick the brains of all the different people in the room. And if you ever want to know anything, if you go up to a person and you say, hey, can I pick your brain for a minute? That person cannot say no. Like, just think about that. Can I pick your brain for a minute? The person that you're asking absolutely 100% cannot say no, because what you just said was, you have knowledge that I want. Share it with me.
Yes.
And I think just about everybody is willing to share. Not all RNs are made the same. Not all RTs are made the same. So you got to approach each one differently. This may have been the biggest statement of the conversation. All of us are working together, collaborating in a big circle, and the patient is in the middle. And if we ever lose that, well, let's just hope we never lose it.
Yeah.
But actually, can we just hope we get it back even more?
I think that's a need, Joe.
Yeah. Like, let's not, like, I want to say, let's not ever lose it. But I'm actually, as I'm about to say that, I was thinking maybe we need to get back to that. Because that's a deep point right there.
Agreed.
RTs, pay attention. Some of the words that are said in RN break rooms and nurses and talk is that the RT's never around. And you know what? You're exactly right. Because RTs do our rounds and then we disappear. So RTs, be present on your floor. Your RNs want you there. They want to see you. They will trust you more. And the respect you are looking for is on the floor in the faces of your RNs, not hidden in the break room. I promise you that 100%. Better human beings. That's a big statement. I may come back to this in just a second. We want to work as a team. That's 100%. We teach to the numbers. That's an unfortunate element of education, to where pass rates and all this other stuff comes into play, and we really lose focus on the essence of being better human beings, providing better patient care. And so I hope any educators watching this recognize that. Vincent is associated with Inspire. Is it medical?
Yes, sir.
Inspire Medical Academy. You can find that on the internet. He'll give you more information on that in just a second. This is not sponsored by that, by the way. It's just who he's with, and so that's fine. We're going to cut to the chase and get to the real bones about what is healthcare and how it is. And don't forget, RTs, if you think it's hard intubating a patient who's not sedated and paralyzed, try doing it upside down in a car or a moving truck. Because paramedics and EMTs have it even harder than we do at the head of the bedside. And so before I turn this over, I always leave this episode with, don't ever forget, this right here stands for average is easy. So don't be it. Vincent, you got any closing words you want to share with anybody?
Joe, fantastic. Absolutely. Average is easy. Be extraordinary. So no, I think all your points are fantastic. Thank you so much for recapping everything. We could all work together and create a better world, guys. We can. And it literally starts everybody thinks, well, how am I going to do this, right? Well, we have to start it in the government. We have to start it in this medical board. Guys, it starts in your hometown, in your home hospital. Do it. It's contagious like a virus. It spreads, no pun intended, okay? I know everybody's burned out from virus talk, but it does. It spreads out. I also want to just say thank you for that little plug. I'm going to plug my little business ploy in there, okay? I am owner, CEO of Inspire CPR. You can find us, www.inspire-cpr.com. We're on Facebook, also Inspire Medical Academy. We do PALS, ACLS, BLS, also Medical Academy stuff, and RN tutoring. So thank you. Appreciate it.
Yeah, hey, real quick before you go, I told you I was coming back to this. You said down here, you said, let's just be better humans. And then you said, you finished, you said, be extraordinary. Hey, Vincent, whenever you get a merch shelf done, that's going to be your shirt. Be extraordinary. I love it. I thank you so much for joining us today. Your words were passionate. They were heartfelt. They kind of got me in my feels. And I just appreciate you being here so much. So having said that, to all the respiratory therapists and the future respiratory therapists watching this, so if you're an RN and you're watching this, we love you. Thank you for watching. Hit the subscribe and the like button. If you're an educator and you're watching this, take some of these words. There's a lot to learn from it. And I'm just so thankful to have this platform. In the meantime, go be great.